Good afternoon, everyone. Welcome to AETCM. I'm Dr. Bharat, and today we'll be going through American Heart Association ACLS 2020 guidelines as a part of our EM Rapid 2022 series. Through this talk, we are trying to convey the important points in basic life support, advanced life support in pregnant women, termination of resuscitation, what are the post-cardiac arrest care that has to be given to a patient, how to neuroprognosticate a patient who had suffered from cardiac arrest, and what are the recent updates in ACLS as per the SARS-CoV-19 infection. Coming to the topic, approximately 350,000 patients suffer from out-of-hospital cardiac arrest in the US. Among these 350,000 patients, only 10.4% survive after the initial cardiac arrest, and among this 10.4%, only 8.2 survive with an intact neurological status. The key for successful resuscitation from out-of-hospital cardiac arrest are layer rescue CPR as well as early use of AEDs. The VLS algorithm pushed out by AHA has tremendously improved out-of-hospital cardiac arrest over the last 2 decades. In spite of that, only 39.2 adults receive layperson initiated CPR in case of a cardiac arrest, and only 11.9% of cases where a AED was used on a cardiac arrest patient. In comparison to this, approximately 1.2% of all adults admitted to US hospitals suffer from in-hospital cardiac arrest scenarios. But in spite of such a high number, more than 25% of patients are discharged alive, and 82% of those survivors have a good neurological status, most probably secondary to the appropriate monitoring as well as early recognition of cardiac arrest that is happening in a controlled environment like hospital. Excellent CPR and early defibrillation for appropriately shockable arrhythmias remain the cornerstone for basic as well as advanced life support. The excellent CPR term is emphasized because anything short of that does not provide adequate coronary or cerebral perfusion, thereby compromising a patient's chances for neurologically intact survival. Now, coming to chain of survival is a series of predetermined events that has to be done for a patient who suffers from cardiac arrest to get the maximum survivability for the patient. In a chain of survival events, the AHA let us know what are the basic headings or basic treatment modalities that need to be done for the patient for a better outcome. So there is a chain of survival for in-hospital cardiac arrest as well as there is a chain of survival for out-of-hospital cardiac arrest. In in-hospital cardiac arrest chain of survival, the chain starts with the early recognition and prevention strategies for cardiac arrest, then followed by activation of emergency responses, early initiation of high-quality CPR, early defibrillation, and post-cardiac arrest care with recovery. While in out-of-hospital chain of survival, the chain starts with activation of emergency responses, rapid recognition of cardiac arrest, and activation of emergency responses, followed by early initiation of high-quality CPR, early defibrillation, and then activation of advanced resuscitation in form of EMS or in a center where advanced resuscitation can be performed, followed by post-cardiac arrest care and recovery. The recovery is a new link added to the chain of survival as per the AHA. Now, coming to basic life support, this is the AHA algorithm for basic life support, which we will be going through in detail in the coming slides. So, the basic life support is basically dealing with a unresponsive patient. So, you find an unresponsive patient lying down, how to approach that patient and how to rapidly recognize cardiac arrest and give the necessary treatment is what BLS teaches us. So whenever you find an unresponsive patient, the first thing that you have to make sure is whether the scene is safe for you to enter and treat the patient or assess the patient. You should not be putting yourself in harm by entering into a situation which is harmful to you. For example, a patient unresponsive lying near a water body or a wet ground with a live electrical wire lying nearby. If you are entering in such a situation, it's most likely that you will also be electrocuted and you will be putting yourself in the way of harm. So first make sure the scene is safe for you to enter, and once you enter, after the scene, verifying scene safety, check for responsiveness of the patient by tapping on his shoulder or calling him by giving good stimulus. Check for responses to elicit any response, and if responsiveness are not there, shout for help and activate emergency services with your handheld devices, mobile phones or any other handheld devices. If you get any help, you should ask the help to get an AED as soon as possible if it is available nearby. After doing so, you have to assess the patient. If the patient is unresponsive, assess the patient for carotid pulse, that is a central pulse, as well as look for any gasping type of breathing or a irregular breathing pattern if it is seen. This assessment should only last for 10 seconds. So in 10 seconds, you need to assess a central pulse, which is preferably a carotid pulse. And along with checking for pulse, you should assess the patient for any breathing movements or absence of breathing movement or gasping like state, which has to be considered as abnormal breathing movement and not sustainable. Now, with this, the algorithm has three different outcomes. The primary outcome is basically patient is unresponsive, but you will get a central pulse as well as there is normal breathing for the patient. In such a scenario, you just monitor the patient and stay with the patient till the emergency medical services arrives at the scene and takes over the patient care. The second scenario is basically the patient's central pulse is present, but patient's breathing is abnormal or absent. In case if breathing is absent or abnormal, you need to stay with the patient and give rescue breaths for the patient while checking the central pulse every 2 minutes. So if every 2 minutes when it says check central pulse, if the pulse is present, you can continue doing the same steps till emergency medicine services arrives and take over the patient. Or in case in any time during the resuscitation that you are doing, if the central pulse becomes absent, we go to the third scenario. Now coming to the third scenario, the third scenario is a scenario in which the patient is unresponsive and you are not getting a central pulse. Or the patient is in a gasping state. So this is a condition that we assess the patient and likely understands that the patient is in cardiac arrest and initiates CPR. Now, these figures show how to assess the central pulse over the carotid artery, and along with palpating for carotid artery, you are supposed to look for any breathing. You are supposed to look for any breathing movements, any abnormal breathing movements or anything. If you get a normal breathing for the patient and carotid pulse is present, then you can put the patient on left lateral position to prevent any secretions pooling on his oral cavity causing airway obstruction. Now, similarly, as we told, if the patient's breathing is abnormal but central pulses are present, we are supposed to give rescue breaths for the patient. A rescue breath is given over a 1 second time duration, and a adequately given rescue breath can cause adequate chest wall movement. Chest wall rising can be seen. Now, before we give rescue breath, we have to make sure that patient's airway is patent. That is, there is no pooling of secretions or any foreign body obstruction there. One of the easiest method is to inspect the oral cavity and see if there are any foreign bodies or secretions there. If it is there, to put the patient on left lateral position and drain it out. If there is no secretions or foreign body obstruction there, before giving rescue breath, we should do airway maneuvers to make sure the airway is fully opened to receive the breath that we are giving. So the airway maneuvers we use is either a head tilt chin lift method or a jaw thrust method. Either of these two we can use. Head tilt chin lift method can be used if the patient that we are attending doesn't have any motor vehicle accident history or any suspected injury to the cervical spine. If those two things are not there, we can use head tilt chin lift manual. If we are suspecting any injury to cervical spine, it's better to do the jaw thrust rather than a head tilt chin lift. Once we do airway maneuvers to make sure the airway is patent, we can give the rescue breath. We can either give the rescue breath mouth to mouth, or we can give a rescue breath mouth to mask if we do have a mask with us at the time of introduction. Now, in case of in-hospital cardiac arrest where you are assessing the patient and you have a BMV, that is back valve mask apparatus available for you, and then it is prudent to use BMV. It's prudent to ventilate the patient using BMV rather than mouth to mouth or mouth to mask. In case of BMV using ventilation using BMV, it's either good to use a C and E grip to stabilize the mask while you give breath through the back, or you can place both thumbs on the side of the mask to securely fit the mask and ask your helper to give rescue breaths. Now, coming to the third scenario as such, in which the patient's carotid pulse are not felt or the patient is in a gasping state with erratic breathing, we have to early recognize the patient to be in cardiac arrest. Now, why this is important to recognize the patient is in cardiac arrest is that during a cardiac arrest, the cerebral as well as coronary perfusion are severely limited or absent, causing the patient to go into irreversible damage and greatly diminishes the chances of recovery with a good neurological survival. Now, here, even if you palpate for central pulse for 10 seconds and you are not sure whether the central pulse is present or absent, and you think a patient may be having a pulse, what you need to do here, understand here is, it's better to initiate CPR if in case of doubt rather than take prolonged time for assessing the patient whether the patient is in cardiac arrest. This is because numerous studies have shown that even if you initiate CPR on a patient who is not in cardiac arrest, the damage done by your cardiopulmonary resuscitation is very minimal in comparison to the loss of time the patient has to suffer due to lack of initiation of CPR. Now, coming to the BLS algorithm, once we understand the central pulse is absent or the patient is in gasping state, we initiate the CPR. The CPR is initiated at 30 compressions followed by 2 rescue breaths, and this is called as one cardiac cycle during cardiac arrest, and use the AED as soon as possible. So before itself we have sent, if at all we have a helper available, we have sent the helper to get us a AED if it is available. In the meantime, we have to start chest compressions at 30 compressions followed by 2 rescue breaths. And whenever the AED arrives, the person who is doing CPR should continue doing CPR while the helper attaches the AED to the patient's body and follows the AED instructions. So AED is basically an automated external defibrillator. This machine has a instructive OS which will help or guide the resuscitators in attaching the machine to the patient and following the orders to deliver a shock if the shock is indicated. So once the AED arrives, the person doing CPR continues doing CPR without stopping while the helper activates the AED by switching it on. And once switched on, the AED will be asking the person to attach paddles to the patient's chest, one over the right infraclavicular area and one over the apex of the patient, and then to plug in the pads, lead connecting the pads to the AED machine. Once the lead connecting to the pad is connected to the AED machine, the AED machine will be asking the person doing CPR to stop CPR to analyze the rhythm. And AED can analyze by itself if the patient has a VT or a ventricular fibrillation to deliver shock. In case the patient is having VT or VF, the AED will be advising shock, and when the AED advises shock, the person doing CPR should continue doing CPR while the helping person can start the process of delivering shock for the patient. And before shock is given, the AED will be asking to stop CPR and move away from patient. And once everyone has cleared the scene, the helper can press the button in AED to deliver shock if it is a shockable rhythm. In case the AED is not detecting a shockable rhythm, AED will be advising to continue CPR for next 2 minutes, after which it will reassess the patient again by stopping CPR to look for any ventricular tachycardia or ventricular fibrillation. So, when we talk about CPR, there is a poster involved in giving excellent CPR. First of all, you have to use the palm of the hand, the base of the palm of your hand. You can use one hand below while curling over your other hand between the fingers and using the palm only to give compressions while the fingers are not in touch with the chest wall, so as to minimize the point of contact. Once you assess the point of contact, basically on the lower part of sternum, either you palpate from the sternum and you palpate from the sternal notch and go down and identify the lower part of sternum, or you palpate up from the lower costal margin and palpate the sternum, then go one hand width above. Once you identify the area, you have to place yourself over the patient so that your entire body weight rests on your hand, and your body is in such a posture that it acts as a fulcrum in delivering direct pressure over the chest wall so as to give adequate compressive strength to cause adequate cardiac compressions. Coming to CPR quality, there are certain performance metrics that we have to keep in mind to say the patient is getting high quality CPR. The performance metrics is basically the rate of compression should be at least 100 compressions to 120 compressions per minute. At least 100 compressions to a maximum of 120 compressions per minute. The compression depth, the depth of compressions given to the patient should be at least 50 millimeters or 2 inches in depth in adults, and not more than 60 millimeters or 2.4 inches in depth. The person who is doing chest CPR should allow for complete chest recoil so that there is good backflow to the heart through the IVC and SVC. There is a good amount of venous return back to heart so that there will be adequate stroke volume for the next compression cycle. And the person giving rescue breath should make sure the patient doesn't receive any excessive ventilation, because excessive ventilation will cause increase in intrathoracic pressure, decreasing venous return back to the heart. And the final metric is the chest compression fraction more than 80%. Now, chest compression fraction is the ratio of chest compressions, the number of chest compressions to the total duration of time that is being given. So a fraction more than 80% is achievable if we do continuously CPR and stop the CPR only to give rescue breaths, and every 2 minutes stop the CPR for rescue breaths, 1 second rescue breaths each, and also to stop CPR for pulse and rhythm assessment less than 10 seconds. If we follow that criteria only, a chest compression fraction more than 80% is achievable. Now, this is basically what an AED is. There are different companies that manufacture AEDs, and a typical AED will look like this. There will be a pad, chest pads, 2 in number, which is available inside the AED with a lead coming out. So once the AED is open, there will be a switch on button. When you switch on the button, the AED will be directing you how to use it. So the first and foremost thing to do is basically place the pads over the patient's chest wall, and then the AED will be asking you to attach the leads to the AED. Once this is done, AED will ask to stop CPR to assess the rhythm that is happening with the patient, and if the AED detects the rhythm to be a shockable rhythm, that is a ventricular tachycardia or a ventricular fibrillation, then the AED will be asking advising shock, in which case you can press the middle button, which is middle button or the red button. Usually it's a red or orange button. You can press that to deliver shock to the patient. Once shock is delivered, we should always make sure to initiate CPR just after the shock is delivered, and do not waste time for checking the pulse, because even if the AED is successful in reverting the patient in VT or VF back to sinus rhythm, the heart may not be in a condition to produce a good pulse volume to be able for us to detect in central pulse. So it's prudent to continue CPR for 2 more minutes and reassess only after 2 minutes of CPR. Now, one of the most important updates the AHA has done in a life advanced as well as basic life support system is the use of naloxone for patients who is suspected to have opioid overdose. Naloxone, being an antagonist of opioid, rapidly can reverse the effects of opioid and make the patient to near normal again. And naloxone can be used in patients when you assess the patient itself. Whenever you find a patient unresponsive and you check the patient's breathing, even if the breathing is normal, if you think the patient is slowly deteriorating, or if the patient is having a decreased respiratory efforts or a decreased respiratory rate, you can think about giving naloxone if the patient is suspected to have opioid overdose. And in the other scenario where the patient is not breathing properly and you check for pulse, pulse is not there, and you start CPR, even then you can think about naloxone if you think the patient is in cardiac arrest due to opioid overdose. Or if you check for pulse and pulse is there and you are supporting the patient with a respiratory effort by giving one rescue breath every 10 seconds, even then you can give naloxone if you think the respiratory depression is secondary to opioid overdose. So, naloxone is basically an opioid antagonist that rapidly reverses an opioid overdose. It can quickly restore normal breathing to a person if their breathing has slowed or stopped because of opioid overdose. It has no effect on someone who does not have opioids in their system. This is why it is being widely pushed by AHA to be given to patients who are suspected to have cardiac arrest, because even if you give, if the patient is not having opioid overdose, it's not going to affect them in a bad way. And the naloxone can be given to the patient as a nasal spray, or it can be injected into the muscle or under the skin or directly into an IV. Naloxone works in the body for maximum 30 to 90 minutes, so that even if you give naloxone and the patient becomes stable enough, you still have to alert the EMS and make sure the patient reaches the hospital for better care of opioid overdose. And people with physical dependence on opioids might go into withdrawal as soon as you give naloxone. So you have to look for any symptoms of opioid overdose also if you give naloxone for the patient. Now coming to adult advanced cardiac arrest algorithm, this is a direct continuation of basic life support itself, and the cornerstone of management for advanced cardiac life support is also excellent CPR as well as early defibrillation for shockable arrhythmias. Once we initiate the patient on ACLS from BLS, we have to first connect the monitors for on the patient, including defibrillator for easy rhythm assessment. And during this time, CPR should be continued. At the 2-minute mark, we can stop CPR, check for the rhythm to assess whether the patient has a shockable arrhythmia like a pulseless ventricular tachycardia or ventricular fibrillation. If it is there, we can give shock. If not there, we can continue CPR. Along with this, the initiation of ACLS itself, we have to have a IV or IO access. Preferably, it should be two large bore IV access if it is possible. If we are not able to achieve a IV access in spite of trying multiple times, we can go for a IO access. Once IV or IO access is available, we can start the patient on epinephrine injection every 3 to 5 minutes. And if the patient has VT or VF, pulseless VT or VF, which is refractory to shock, after 3 shocks, we can start the patient on amiodarone or lidocaine. One more thing that we have to start the patient, we can try on the patient once the ACLS is being started, is placing a advanced airway. Now, advanced airway means we can either insert a supraglottic airway device or an endotracheal tube onto the patient. If you are using an endotracheal tube, it will be prudent to use a end-tidal CO2 for monitoring the CPR quality as well as to assess how the patient is faring during the cardiac arrest. End-tidal CO2 value of less than 20 and progressively decreasing shows that the CPR quality may be decreasing and has to reassess the CPR metrics. During all this time, continuous CPR has to be done at continuous CPR has to be done at 100 to 120 compressions per minute at a 2.5 to 2.6 inches depth. CPR quality has to be monitored using either end-tidal CO2 or invasive arterial line insertion with arterial line tracing, and CPR quality has to be improved and continuous CPR has to be given. Along with this, we can think about treating the reversible causes that can cause cardiac arrest, which are classified into 5H and 5Ts. At every 2 minutes, we can stop CPR and check for an organized rhythm in the defibrillator. If an organized rhythm is there, check for pulse. If organized rhythm is not there, we can continue CPR without wasting time for pulse check. Now, at the time of pulse check, if we are getting a good pulse in a central pulse, then we can stop CPR and continue to post cardiac arrest care. But if we are not getting a pulse, we can continue CPR. Along with this, another indicator of a ROSC, that is return of spontaneous circulation, is a sudden increase in EtCO2 values when during CPR. Now, as we told, cardiac arrest causes can be multiple reasons, but there are certain reversible causes that we can think about during cardiac arrest, and those are classified into 5H and 5Ts. Now, the things that come under 5H is basically hypovolemia, hypoxia, acidosis, that is hydrogen ion excess, that is acidosis, hypo or hyperkalemia, and hypothermia. While 5Ts contain tension pneumothorax, cardiac tamponade, toxins, pulmonary thrombosis, and coronary thrombosis. Now coming to advanced cardiac life support. Advanced cardiac life support is a continuation of basic life support itself. It initiates in a hospitalized setting when there is a cardiac arrest in a hospitalized setting, or when a EMS team or an advanced cardiac team arrives on the scene and take over the resuscitation from the BLS provider. That's when the ACLS starts, and ACLS management, like BLS, is the excellent CPR quality and early defibrillation of shockable rhythms. That forms the cornerstone of management even in ACLS. The difference in BLS and ACLS is basically in ACLS we give IV drugs, as well as we assess the rhythm and think about the reversible cardiac arrest cause that we have dealt earlier. The reversible cardiac arrest has to be evaluated, and that treatment should also be given to the patient. Now, coming to ACLS as such, once the ACLS teams take over the treatment or cardiac arrest proceedings of the patient, initially itself one person takes responsibility of CPR and continues CPR at the rate of 30 to 2, 30 compressions per 2 rescue breaths. That ratio is maintained and CPR is continued. CPR should not be paused or delayed when the takeover from BLS to ACLS starts. And as the CPR is ongoing, we can attach monitors and defibrillator to the patient side for easy assessment of the patient. And we can think about, in a hospitalized settings, we can think about accessing a IV access, but in a primary setting, AHA haven't asked us for a definitive airway or IV access in the early phases, mainly because if at all the patient is in a shockable rhythm, early defibrillation might bring the patient back, and it's prudent not to waste valuable time in going for definitive airway or IV access if you do not have the resources or personnel or expertise in getting that. That is why initially AHA is not asking for an advanced airway or IV access, but definitely if you have the personnel to spare, or if you have the expertise to get IV access or definitive airway without disrupting the CPR and rescue breaths, of course we can do that. It's not a contraindication. Now, coming to the ACLS algorithm, there are two algorithms basically. One for shockable rhythm, that is pulseless ventricular tachycardia or ventricular fibrillation, and another for non-shockable rhythm, that is asystole or pulseless electrical activity. Now, as we have initially told, CPR is ongoing. We have started the patient, we have attached the patient to monitors and defibrillator for easy rhythm access, and we have also started providing oxygen for the patient during rescue births. And at the 2-minute mark, when we are checking for the rhythm, what we check for is whether there is an organized rhythm present in the defibrillator. In a cardiac monitor or a defibrillator, if there is an organized rhythm, then we go for a central pulse presence, checking for central pulse if it is present. If there is no organized rhythm, do not waste time for checking central pulse. We can go ahead with the protocol. So if at all in the monitor it shows a shockable rhythm, we have then the diagnosis of pulseless ventricular tachycardia or ventricular fibrillation is made, and we have to give defibrillation for the patient as soon as possible. So this first defibrillation should be given as soon as possible, and once the defibrillation is given, we have to continue CPR. Now, when you give defibrillation for the patient, usually we use biphasic defibrillators, but there are monophasic defibrillators also. In case of biphasic defibrillator, the maximum joules that can be given is around 220 joules. Initially, you can give between 120 to 220 joules. Energy can be anywhere between 120 to 220 joules. You can start off in a biphasic defibrillator, but the subsequent defibrillations, the subsequent shocks that you deliver should be equivalent or higher than the initial shock that you are given. So initially if you are given 120 joules, the second shock should be either equal to 120 or higher than 120. It is preferred to be higher, because if in 120 joules, if the patient is not reverting, then it's preferred to be using a higher joules. Now, if you are using a monophasic defibrillator, the joules should be 360 joules, fixed joules, 360, that's the maximum joules that should be given. And as soon as the defibrillation is done, the CPR should be continued without waiting for a pulse check, and at that point we can put a IV access. In case you are not able to secure a IV access, or if you lack the expertise to get IV access, because there can be venous collapse and it can be difficult to get IV access, in that case do not waste time and get a IO access as soon as possible. Now, this has to be done within the next 2 minutes, and in next 2 minutes when we recheck the rhythm, we are checking whether it's still in shockable rhythm or a non-shockable rhythm. If it is in shockable rhythm, we have to give the second defibrillation there itself. Once the second defibrillation is given, we are continuing CPR. Along with that, we are giving the first dose of epinephrine. The first dose of epinephrine is given after the second dose, not in the first dose, after the second dose only. And hereafter, epinephrine can be given every 3 to 5 minutes. And at this point itself, we can think about putting an advanced airway for the patient. When we say advanced airway, it can either be a supraglottic airway device like a laryngeal mask airway, or we can go for a endotracheal intubation. If you are putting a supraglottic airway device, we have to, if either supraglottic airway device or endotracheal intubation is being done for the patient, we have to make sure that patient is monitored with the ETCO2 for positioning, to make sure we have intubated the patient in trachea itself, and as well as to continued monitoring of CPR quality and ventilation quality of the patient. ETCO2 monitoring can be continued. Along with this, if we have a advanced airway, the rescue breaths that should be given is every 6 seconds, one breath every 6 seconds. So total 10 breaths in a minute should be given for the patient. But if advanced airway is not placed and we are continuing with the bag mask ventilation, we can give each rescue breath, 2 rescue breaths after 2 minutes of every 30 compression. After every 30 compression, we can give 2 rescue breaths for the patient, like we were doing in BLS. Now, after the second shock, we have continued CPR for 2 minutes. Again, we are coming to rhythm check, and we are seeing whether the patient has got a organized rhythm or not, and if it is still in a shockable rhythm, we give the third defibrillation. Now even after third defibrillation, and we continue CPR, and epinephrine is given, and at this time we have to think that patient is refractory to the defibrillation that we have given, and we have to think about giving IV drugs. One of the most common IV drugs that we give is amiodarone. Amiodarone first dose is 300 mg IV bolus, and at that point we can also think about the reversible causes, the 5H and 5Ts that we have talked about. We can think about the 5H and 5Ts that can cause persistent refractory VF or pulseless VT in the patient, and treat those reversible causes. Now after this third shock also, in 2 minutes when we reassess the rhythm, if the patient is still in shock, we can give the second dose of amiodarone, that is 150 mg IV bolus, and epinephrine, and continue CPR. And this algorithm continues till we get the patient either in a ROC, return of spontaneous circulation. Once we get the patient in return of spontaneous circulation, we can go into post-cardiac arrest care. If not, we have to continue this algorithm, assessing whether the patient is in shockable rhythm or non-shockable rhythm each time. And if it is shockable rhythm, we can continue delivering defibrillations. If it is in non-shockable rhythm, we will go to the next algorithm that we will be coming right now. Now coming to any situation in which when we assess a rhythm, there we are not getting any organized rhythm, and when we check it is a non-shockable rhythm, that is a systole or a pulseless electrical activity, the first and foremost thing is we should give epinephrine as soon as possible at that moment itself. So before when we check the rhythm and we get a asystole PA, then itself we should give the first dose of epinephrine here and start CPR. CPR should be continued for 2 minutes at either 30:2 compressions, 30 compressions per after each 2 rescue breaths, or we can put a definitive airway, then give ventilation to the patient at the rate of 10 breaths per minute. We can put as like a VFVT, we can put a ETCO2 monitoring to assess the CPR quality as well as ventilation quality over here, and in every 2 minutes stop CPR and recheck the rhythm. If the rhythm is remaining in a non-shockable state, that is asystole or PEA, continue giving epinephrine and continue CPR. If the patient goes into a shockable rhythm, we go to the VFVT algorithm till the patient achieves ROC, that is return of spontaneous circulation. Now, how will you know the patient has got a return of spontaneous circulation? Patient, whenever the patient gets into a return of spontaneous circulation, so we can first of all we can check for pulse, or every 2 minutes when we check for pulse. If we get a palpable pulse, we can understand patient has got return of spontaneous circulation, or else there will be abrupt increase in ETCO2 monitoring that we are doing. Usually ETCO2 will rise more than 40 millimeters of mercury. That can show that patient has achieved a return of spontaneous circulation. And if at all the patient is having an intra-arterial pressure monitoring line, we can see spontaneous arterial pressure waveforms forming when the patient achieves return of spontaneous circulation. Now, coming to assessment of management, that is how we can assess whether the management that we are giving is of good quality. We have certain markers for that. One of the physiological markers is ETCO2. ETCO2 is end-tidal carbon dioxide volume. So it is a quantitative waveform capnography. If we use that, if the quantitative waveform capnography is more than 20, we can make sure that we are doing a good quality CPR. If it falls below 20, then we have to take steps to improve our CPR quality. Another measure that we can use is arterial diastolic pressure. So if we have a intra-arterial pressure monitoring kit placed on the patient, we can look at the arterial diastolic pressure. If diastolic pressure is becoming too low, we have to increase our CPR quality. Arterial pressure monitoring will be good to assess the CPR quality and patient's prognosis, and central venous oxygen saturation can be used for further assessment of the patient. Now coming to cardiac arrest in pregnancy, maternal cardiac arrest is a very challenging situation because we have the life of the mother as well as the child to be saved, and maternal cardiac arrest management is very stressful, and it's very difficult to get a good outcome out of this. So in these scenarios it should be pre-planned. There should be a hospital maternal cardiac arrest team formed. It should be a combined team made up of obstetric team, neonatal team, the emergency services, anesthesiology, as well as the intensive care team for giving absolutely best care for the mother as well as the child. Now, the priorities in pregnant women's cardiac arrest. Basically, the care for pregnant women cardiac arrest, there are two major things that we have to take care of. One is, as we have been telling, it's the high quality CPR, and the second thing is relief of aortocaval compression due to the gravid uterus by lateral displacement. So gravid uterus should be laterally displaced so that aortocaval compression can be minimized, so that there will be a return of venous blood flow to the heart, as well as the aortic compression will be relieved of to facilitate better circulation. All pregnant women, when they are in cardiac arrest, we have to alert the team at the time of cardiac arrest itself, because perimortem cesarean, if we are planning, it is brought the benefit to improve the resuscitative maneuvers and success of resuscitation for both mother and child. So if at all perimortem cesarean is planned, ideally it has to be performed within 5 minutes of the initiation of CPR, and it should be only performed if there is adequate personnel and resources along with the skill set to do it properly. Now, whenever a cardiac arrest, pregnant cardiac arrest is happening, usually pregnant females have a difficult airway, and because of that difficult airway, the personnel with the most experience should be should be putting the advanced airway for the patient to minimize the interruption in CPR and to save time. And endotracheal intubation or supraglottic airway device can be used here, and waveform capnometry can be used to assess the CPR quality as well as ventilation quality. Once advanced airway is in place, rescue breath should be given like ACLS itself, that is 1 breath every 6 seconds, that is 10 breath every minute. Now, when we come to algorithm, the same algorithm like ACLS is being addressed here. High quality CPR should be given, defibrillation, early defibrillation whenever we get a shockable rhythm, and other ACLS like the IV drugs, epinephrine in both scenarios, and amiodarone or lidocaine to be given during VF-VTs can be given if at all the patient is in pulseless VF or pulseless VT. And within at the time of cardiac arrest itself, we inform the maternal cardiac arrest team, which comprises of other specialty specialists also, and we have to consider the causes of maternal cardiac arrest. There are 5H and 5Ts that we have already mentioned. Other than the 5H and 5Ts, we have anesthetic complications, the bleeding disorders for the pregnant female, and cardiovascular disorders, drugs that can cause cardiac arrest, pulmonary embolic due to either amniotic fluid or from DVT, which can also be commonly found in pregnant women. It can also due to generalized fever or general non-obstetric causes of our cardiac arrest, that is the 5H and 5T, and also it can be severe hypertension like in eclampsia or preeclampsia. So maternal interventions is similar to the adult intervention, except that we have to take care of two main things, that is try to place a IV above the diaphragm, and also if receiving IV magnesium, we have to stop and give calcium chloride or calcium gluconate for the patient. And we have to remove the aorta caval compression by gravid uterus by lateral displacement. And obstetric interventions usually is continuous lateral uterine displacement, and fetal monitors should be detached because it can interfere with the maternal monitoring system, and prepare for perimortem cesarean delivery within 5 minutes of initiation of CPR. if at all patient is not revived within 5 minutes of initiation of CPR. And once perimortem cesarean is done, if no ROC within 5 minutes, we can do the perimortem cesarean delivery, and neonatal team should receive the neonate for further resuscitation. Now coming to termination of resuscitation, using a validated termination of resuscitation rule will help ensure accuracy in determining futility in certain patients, and futility is defined as less than 1% chance of survival. This termination of resuscitation rule should be valid by demonstrating a high accuracy for predicting futility with a lower confidence limit greater than 99% with external validation. The TOR rule will aid both in resource utilization and optimizing a patient's chance of survival. The BLS TOR rule is otherwise called as Universal TOR rule. The TOR is termination of resuscitation rule, has been significantly prospectively validated as in both BLS as well as in ACLS systems. The many retrospective analyses have found that application of universal termination of resuscitation rule at 20 minutes of resuscitation was able to predict futility, identifying over 99% of survivors and patients with a good neurological outcome. An ETCO2 level less than 10 mm of mercury after 20 minutes of advanced life support resuscitation is strongly but not perfectly predictive of futility. This can also be used as one of the components of a multi-modal approach to determine termination, but it should not be used alone. Now, these are the termination rules, BLS termination of resuscitation rule and ACLS termination of resuscitation rule. Both are being significantly evaluated and prospectively supported. In BLS, what we are looking at is a arrest which was not witnessed by emergency medical services and no return of spontaneous circulation before transport to a higher center, and no AET shock was delivered before transport. If all three criteria are met, consider termination of resuscitation after 20 minutes of resuscitation. If any of the criteria are missing, continue resuscitation and transport the patient to a advanced care unit. Now, coming to ACLS termination of resuscitation rule, arrest should not be, one of the criteria is arrest not witnessed, no bystander CPR, no return of spontaneous circulation before transport like BLS rule, no shock was delivered before transport like BLS rule. If all four criteria are met, we can consider termination of resuscitation after 20 minutes. If any criteria are missing, continue resuscitation and transport the patient to the intensive care. Now, coming to post-resuscitative care, post-cardiac arrest care is a critical component of the chain of survival. The systemic impact of the ischemic perfusion injury caused by cardiac arrest and subsequent resuscitation requires post-cardiac arrest care to simultaneously support multiple organ dysfunctions that can be affected due to the cardiac arrest. Many patients who survive cardiac arrest event will eventually die because of the withdrawal of life-sustaining treatment in the setting of neurological injury. Because of this, much of the post-cardiac arrest care focuses on mitigating injury to the brain. After initial stabilization, care of critically ill post-arrest patient hinges on hemodynamic support, mechanical ventilation, temperature management, diagnosis and treatment of underlying causes. Vigilance for and treatment of infection should also be taken care in these patients. Possible contributors to the decrease in cerebral injury include optimization of cerebral perfusion pressure, management of oxygen and carbon dioxide levels, control of core body temperature, and detection and treatment of seizures. Cardiac arrest results in heterogeneous injury, thus death can also result from multi-organ dysfunction or shock. In light of the complexity of post-arrest patients, a multidisciplinary team should be taking care of them. Coming to targeted temperature management or TTM, a temperature between 32 degrees Celsius to 36 degrees Celsius for at least 24 hours is currently recommended for all rhythms, either in hospital cardiac arrest or out of hospital cardiac arrest survivors. There is no clear best approach for rewarming after the TTM, although a protocol of studies have seen using 0.5 degrees Celsius per hour rewarming. The optimal rate of rewarming and specifically whether slower rates are beneficial is still a knowledge gap. Fever after return of spontaneous circulation is associated with poor neurological outcome in patients not treated with TTM. Although this finding is pretty inconsistent in patients treated with TTM also. There is the treatment of fever is associated with the improvement is not really proven with trials, but treatment or prevention of fever appears to be a reasonable line of management. Now, percutaneous coronary intervention can be considered in a patient with a CAD, especially since CAD is one of the prevalent causes of cardiac arrest. Patients with cardiac arrest due to shockable rhythms have demonstrated particularly high rates of severe CAD. When significant CAD is observed during post-cardiac arrest coronary angiography, revascularization can be achieved safely in most cases. Recommended emergency coronary angiography for patients with ST segment elevation on the post-ROSC ECG. Now, this is a post-cardiac arrest algorithm. Once the ROC is obtained, we manage the airway. Early placement of endotracheal tube is indicated if the patient is having unresponsiveness or unconsciousness, and manage respiratory parameters. Start 10 breaths per minute. SpO2 should be managed between 92 to 98% with a PaCO2 target between 35 to 45 millimeter of mercury. Hemodynamic parameters should also be controlled with a systolic blood pressure more than 90 and mean arterial pressure more than 65 managed. We should obtain a total lead ECG to rule out ST segment elevation MI. If ST segment elevation MI is there, we should consider for early PCI, percutaneous coronary intervention. If unstable cardiogenic shock or mechanical circulatory support is required, we should also plan for PCI for these conditions. If total lead ECG is normal or doesn't have any ST segment elevation MI, we can think whether the patient is following commands or not. If following commands, if patient is awake, and we can give to critical care unit for further management. If comatose, then we can start the patient on TTM, that is targeted temperature management. Plan for a brain CT to rule out any intracranial hemorrhages, EEG monitoring to rule out non-convulsive status epilepticus or seizures. If present, we have to manage seizures or non-convulsive status epilepticus, and other critical management that we have mentioned earlier for making sure the brain doesn't have secondary injuries. Now, coming to updates regarding COVID-19, these are the interim guidelines that came out in 2020. Don person protective equipment before CPR, minimize the number of clinicians performing resuscitation, and preferably use a negative pressure room if it is available. Mechanical use device is encouraged if resource and expertise are available. Use of high efficiency particulate air filter, HEPA filter, while ventilating will be able to decrease the contaminants that is circulating. Emphasize early intubation and try to achieve first pass success early itself. Use of laryngeal video laryngoscopy is also encouraged. Use supraglottic airway device or bag valve mask ventilation with tile seal if intubation is delayed. Avoid prolonged resuscitation efforts and consider extremely high mortality of adult COVID-19 patients in cardiac arrest, and consider lapses in infection control and associated risk during the resuscitation. Prone chest compressions can be initiated if the patient is intubated by pushing on the chest wall behind the heart. COVID-19 patients are at increased risk of thromboembolic complication, and that has to be kept in mind during resuscitation. Now, coming to neuroprognostication, hypoxic ischemic brain injury is the leading cause of morbidity and mortality in survivors of out-of-hospital cardiac arrest and accounts for similar but significant portion of poor outcomes after in-hospital cardiac arrest resuscitations also. Most deaths attributable to post-arrest brain injury are due to active withdrawal of life-sustaining treatment based on predicated poor neurological outcome. Accurate neurological prognostication is important to avoid inappropriate withdrawal of life-sustaining treatment in patients who may otherwise achieve meaningful neurological recovery, and also avoid ineffective treatment when poor outcome is inevitable. Interpreting the results of diagnostic test and correlating those results with the possible patient outcome should be done for all survivors, given that a false positive test for poor neurological outcome could lead to inappropriate withdrawal of life support. Any single method of neuroprognostication has an intrinsic error rate and may subject to confounding. It's better to go for multiple modalities to neuroprognosticate the patient to improve the accuracy. Neuroprognostication incorporates multiple diagnostic tests that are synthesized into a comprehensive multimodal assessment at least 72 hours after return of spontaneous circulation and after return to normothermia, with sedation and analgesia limited as possible. When performed in combination with other prognostic tests, it is reasonable to consider some clinical parameters as well as some biochemical parameters. Clinically, we can look for bilaterally absent pupillary reflex, bilaterally absent corneal reflex, quantitative pupillometry, myoclonus that occurs within 72 hours after cardiac arrest if EEG doesn't have cerebral correlation. In biochemicals, high serum levels of neuron-specific enolase (NSE) within 72 hours can also be used as a prognostic marker in combination with other modalities. Electrophysiologically, persisting status epilepticus after 72 hours of cardiac arrest is a poor prognostic marker. Burst suppression in EEG in the absence of sedating medicines is also poor after 72 hours. Bilaterally absent N20 somatosensory evoked potential, that is SEEP waves after 24 hours of cardiac arrest is also a poor prognostic factor. Absence of EEG reactivity within 72 hours after cardiac arrest should not be used for prognosis. In neuroimaging, reduced gray-white ratio on CT brain plane can be used to support poor prognosis. Extensive areas of diffusion restriction or restricted apparent diffusion coefficient can be used for supporting poor prognosis after 2 to 7 days of cardiac arrest. Now, this chart shows the neuroprognostic modalities that we have discussed in the previous slides in a time-based management, that is after ROSC within 24 hours, 48 hours and 72 hours. Now coming to recovery and survivorship. This is the new additional link in chain of survival, recovery expectation and survivorship plans that address treatment, surveillance and rehabilitation need to be provided to cardiac arrest survivors and their caregivers at hospital discharge to address the sequelae of cardiac arrest and optimize the transitions of care to independent physical, social and emotional functions. Recommendations that critically important to this concept include recommended structured assessment of anxiety, depression, post-traumatic stress and fatigue for cardiac arrest survivors and their caregivers. Recommend that cardiac arrest survivors have multimodal rehabilitation assessment and treatment for physical, neurological, cardiopulmonary and cognitive impairments before discharge. It's also recommended that cardiac arrest survivors and their caregivers receive comprehensive multidisciplinary discharge planning to include medical and rehabilitative treatment. Now, to take home messages. On recognition of cardiac arrest event, one should simultaneously and promptly activate the emergency response system and initiate CPR. Performance of high quality CPR. Early defibrillation with concurrent high quality CPR is critical to survival when sudden cardiac arrest is caused by ventricular fibrillation or pulseless electrical tachycardia. Administration of epinephrine with concurrent high quality CPR improves survival, particularly in patients with non-shockable rhythms. Recognition that all cardiac arrest events are not identical is critical for optimal patient outcome, and specialized management is necessary for many conditions, which includes the 5H and 5Ts and cardiac arrest in pregnancies. The opioid epidemic has resulted in an increase of opioid-associated out-of-hospital cardiac arrest. With the mainstay of care remaining the same, we should think about using naloxone as early as possible. Post-cardiac arrest care is a critical component in the chain of survival and demands a comprehensive, structured, multidisciplinary system for it. Prompt initiation of targeted temperature management is necessary for all patients who do not follow commands after ROSC to improve neurological outcome. Accurate neurological prognostication in brain-injured cardiac arrest survivors is critically important to ensure the patients with significant potential for recovery are not destined for certain poor outcome due to withdrawal of care. Recovery expectation and survivorship plans that address treatment, surveillance, rehabilitation need to be provided to the cardiac arrest survivors and their caregivers at the time of discharge. Thank you.